Welcome back. Today, the topic of discussion will be about the fascicular block and the bundle branch blocks. So, we'll start with the simple fascicular blocks. As we all know, there are two types of fascicular block. One is the left anterior fascicular block, and the second one is the left posterior fascicular block. Now, jumping straight into the topic, what are the ECG findings of fascicular left anterior fascicular block? We all know that left anterior fascicular block is the most common causes of left axis deviation. So the ECG will have evidence of left axis deviation. This is the first point. The second point will be there will be evidence of a small Q wave in a small Q wave plus a tall R wave in leads 1 AVL, and the evidence of a small R wave plus a deep S wave in leads 2, 3 AVF. And then the other finding will be a peak R wave peak time. The R wave peak time in lead AVL will be more than 45 milliseconds. And then there will be the other supporting evidence will be that the QRS voltages will be increase in QRS voltage, and sometimes the QRS duration can be prolonged up to 120 milliseconds. Usually they are not prolonged as in bundle branch blocks, and up to 120 milliseconds you can have this QRS voltage. So these are the ECG findings. First is the left axis deviation and QR. So what do I mean by QR complex? A small q means this is the P, and the Q should be small. So this will be very small Q, and capital R is a tall R wave. So they will have a tall R waves. And this will be seen in lead 1 and AVL. And RS complex may mean small r. This is a P, and this is a small P, and you have a small r and a deep S wave. This is the what is called as an RS complex. This will be seen in lead 2, 3 AVF. And the R wave peak time is that when there is a starting of the QRS complex to the peak of the R, that this duration will be more than 45 milliseconds. There will be a slow prolonged R wave in the lead AVL. And high QRS voltage means the height of the QRS will be tall in the limb leads, and the duration is more than up to 120 milliseconds. This can be prolonged. So this is the ECG findings typical of left anterior fascicular block. I'll show ECG and explain it. This will be more clear. For fascicular blocks, always just you need not look at the chest leads. For fascicular blocks, only the limb leads needs to be seen. You can diagnose it directly based on the limb leads. You should know axis determination. You can see the previous video on axis determination. You must know that before you can diagnose any fascicular blocks. So you look at lead 1 and AVL. So first finding. The first one is the left axis deviation. We will calculate the axis. So how will we calculate the axis? Look at lead 1, 2 and AVF. Does this have the tallest QRS complex? No. They do not have the tallest QRS complex. Then we look at lead 3 and AVL. 3 and AVL has the tallest QRS complex? Yes. AVL has the tallest QRS complex. And lead 3 is negative. So this is an example of left axis deviation. And we know AVL has a degree of minus 30 degree. So first finding is that there is left axis deviation. And the second one will be the look at lead 1 and AVL. So you have a small Q wave and a tall R wave. So this is an example of a QR complex. It is seen in lead AVL, and lead 1 there is also a small Q and a tall R wave. So QR complex is seen in lead 1 and AVL. And you can also see in the lead 2, 3 AVF, the inferior leads, there is a small R wave. Small R wave as well as followed by a deep S wave. So this is in lead 2, 3 AVF. So you have a small R wave and a deep S wave in 2, 3 AVF. So this satisfies the third criteria. And look at AVL. AVL in the beginning of the QRS complex to the peak of R wave. It somewhere peaks around this place. it is around more than one small box. So it shows a slow peaking of R wave. The R wave prolongation is more than up to 45 milliseconds. So we find that left axis deviation is there, and QR complex in 1 AVL and RS complex in lead 2-3 AVF. R wave peak time is more than 145 milliseconds, and QRS voltage, you can see the QRS voltage are quite high. I mean, not so significantly high, but okay, you can say that QRS voltage is increased, but the QRS duration is not prolonged. So all these are example findings suggestive of left anterior fascicular block. Then, what are the findings suggestive of left posterior fascicular block? Now, left anterior fascicular block is very common and is one of the most common causes of left axis deviation. But left posterior fascicular block is one of the, you have to think it as a lost cause of right axis deviation. Nevertheless, the ECG should show evidence of right axis deviation. And then it will be exactly opposite. The RS complex will be seen in lead 1 and AVL, and QR complex will be seen in lead 2, 3 and AVF. And then you have to find R wave interval, the prolonged R wave peak time. R wave peak time in lead AVF more than 40 milliseconds. So right axis deviation, RS complex in 1 and AVL, QR in 2-3 AVF, prolonged R wave peak time in AVF, and again the same 5 and 6. Increase in the QRS voltage, and sometimes the QRS duration can be increased up to 120 milliseconds. So these are the findings of left posterior fascicular block. I will show you the ECG. The first thing we have to see is we have to calculate the axis. We know lead 1, first look at lead 1, 2 and AVF. Do they have the tallest QRS complex? I mean, it's similar, but lead 3, you can say, is got a little higher complex than lead 2. So 1 to AF doesn't have the tallest QRS complex. Go to lead 3 and AVL. This shows that lead 3 has a positive QRS complex and AVL has a negative QRS complex. So this gives an example of right axis deviation. Okay, so we know lead 3 has a degree of 120 degree. So this is around, there is definitely right axis deviation is there. Okay, so first point is meet. Then you have to look at lead 1 and AVL. Lead 1 and AVL, you can see there is a small upward curve, R wave, a small R wave as well as a deep S wave. You see RS complex in lead 1 and AVL, and 2, 3 AVF you can show this that a Q wave, a small Q wave and a tall R wave. QR complex in lead 2, 3 and AVF. So this second and third criteria are met up. Then look at AVF. AVF, this no, here it is not meeting, this fourth criteria is not there, but you can see that R wave peaking is a little slurred. So sometimes it can be prolonged up to more than 0.4 meter seconds. And the other thing will be the increase in the QRS voltage and QRS duration. These are all additional criteria, and these are the main criteria. These 3 points are the main criteria. So this gives examples of left posterior fascicular block. Now, I have started with the ECG because people want to know the most important thing up front. So I have started with the ECG. Now, how does all this happen? Now, how do you understand this? Is it necessary you should mug up, or can you have some conceptual understanding behind this? We will go into it. So we all know the conduction system. The conduction system, we know that the impulses from SA node goes to the AV node to the interatrial pathways and the atrial musculature. From the AV node, the impulse goes to the bundle of His. From the bundle of His, it divides into a right fascicle and a right bundle and the left bundle. The left bundle has got two branches, the left anterior fascicle and a left posterior fascicle. You have the left bundle has got two divisions. So SA node, AV node, our right bundle, and left anterior fascicle and left posterior fascicle. So this you should know. This is the conduction of the anterior and posterior fascicle will result in ventricular depolarization. Okay. Now, before jumping into this thing, we have to know the two groups of leads. If you consider this is the cardiac axis, lead 1 and lead AVL. These are superior and left leads, whereas lead 2, 3, 2 AVF and 3 AVF and 2, these are inferior and right leads. So when you are looking into axis deviation, you should see it together. Look at one AVL and then look at 2-3 AVFs and look calculate axis. This is one of the simpler methods. Now, how does the okay, now we will be considering about how the fascicles depolarize the ventricles. Now we all know that right bundle RB, right bundle will depolarize the RV, leave that. Now we are interested in LV depolarization. LV depolarization occurs by means of two fascicles, left anterior fascicle and the left posterior fascicle. These two fascicles will depolarize the left ventricle. So how does left anterior fascicle depolarize? This diagram will help you understand the depolarization. The left anterior fascicle has got a first vector 1 is a minor vector and the vector 2 is the major vector. And again, left posterior fascicle has got two vectors. Vector 1 is the minor vector and the vector 2 is the major vector. So normally this vector 1 will cancel each other and the mean vector is towards the 60 degree. When impulse is conducted via both left anterofascicle and posterior fascicle, the mean axis is around 60 degree. The left anterofascicle initially activates towards superiorly and towards the left. Remember what are the superior and left leads? The 1 AVL. It initially goes towards 1 AVL and then comes back inferiorly and towards the right. That is the 2-3 AVF. And in case of left posterior fascicle, initially goes towards the goes inferior and to the right. There is example of the 2-3 AVF, and then the major vector goes superiorly and towards the left. That is towards the axis 1 and AVL. So why I am saying is that normally when we have, for example, we will start with left anterofascical block, LAFB. So LAFB, we know that left anterofascicle has it is a thin bundle. It has got a single blood supply. It is seen in the LVOT. It can be sensitive to the pressure change of the LVOT, and it is very close to the right bundle branch. So any LAD infarction or any LAD occlusion can produce RBB with an LAFB. This is called as a bifascicular block. We will be dealing with it later. And this is more prone to injury. LAFB is more prone for injury and it is very more common than LPFB. So LAFB, what happens when the left anterior fascicle is blocked? Consider this thing, left anterior fascicle is blocked. Then what will happen? So this will not happen. So only the left posterior fascicle will conduct. So first vector will go towards, first vector will go towards inferior and right. So 2-3 AVF will have a positive deflection, a small R wave in 2-3 AVF, and then the second vector, this is vector 1, and the second vector, the main vector, will go superior and towards the left. So this will produce in lead 1 and AVL will have a tall R wave. And here because it goes inferior towards right, lead 1 and AVL will have a small Q wave. Here 2-3 AVF will have a deep S wave. So you got the finding. So 1 AVL will have a small Q followed with the D. 1 AVL will have a small Q followed by a tall R. This will be seen in 1 and AVL, whereas 2-3 AVF will have a small R followed by a deep S wave. This will be seen in 2-3 AVF. This is because of the vector 1 and this is because of the vector 2, the main vector. Here this is because of the vector 1 and this is the vector 2. You can see when the left anterior fascicle is blocked, the impulse will be conducted only through the posterior fascicle, and your vector 1 is directed inferiorly and towards the right. So 2-3 AF will have a positive wave, that is the R wave, and 1 AF will have a negative wave, that is a Q wave. Then the main vector, when it goes superiorly towards the left, then the opposite will happen. 1 AF will have a tall R wave and 2-3 AF will have a deep S wave. So these are the changes that is seen in, and you obviously have a left axis deviation. Because of this finding, we'll have a left axis deviation. So this all the four findings of LAFB are explained here. So you know left axis deviation, you know as RS into 3 AVF, a small QR and 1 AVL, and since the AVL is the because of the slowness and conduction, because of the fascicular block, because of the left anterofascicular block, there will be prolongation of the AVL time will be prolonged more than 40 milliseconds. So this explains all the findings. Now we will explain left posterior fascicle. LPFB, again, what are the important facts about LPFB? LPFB is actually very rare and is one of the rarest cause of right axis deviation. Why? Because it's a thick bundle. It's thick bundle. It has got good blood supply, and is far away from right bundle branch. So RBB plus LPFB is a very unusual combination, and LPFB is present in the LV inflow, so it is not sensitive to pressure. It does not expose to significant pressure changes. So this is a rare finding, left posterior fascicle block. Okay, so what happens in left posterior fascicular block? Again, the opposite happens. The impulse will not conduct through the left posterior fascicle. Impulse conduction will be absent. So impulse will be conducted only by the left anterior fascicle. So LAF will only conduct the impulses. The first vector goes this way, and the second main vector goes this way. So first vector goes this way. This will produce a small R wave in 1, and AVL will have small R wave. At the same time, a small Q wave in certain 2, 3 and AVF, because 1 AVL is this side, 2, 3 AVF are this side. I'm oversimplifying, but this will help your understanding. So this will be the first wave, and then the main wave of depolarization will produce significant Q waves, significant R waves. Main wave of depolarization will produce a significant R wave in 2, 3 AVF. So you have an Q R complex in 2, 3 AVF, and opposite an R and DPS complex in 1 AVL. So this explains the findings of LPFB. You have an RS, right? You have right axis deviation, RS complex in 1 AVL, and QR complex in 2, 3 AVF. So once again, summing up the finding, there is right axis deviation, there is RS complex in 1 AVL, QR complex in 2, 3 AVF, and the prolonged R wave peak time in AVF more than 0.4 small seconds. This is because there is left anterofascical conduction block, so this will delay the electrical impulse conduction. So this sums up the findings of fascicular blocks. Then you have to know about what there are few findings, what is called as the monofascicular blocks. We'll quickly just pass through it. Monofascicular blocks, there are 3 in number. One is the right bundle branch block, and the other is a left anterofascical block or a left posterior fascicle block. All these 3 things are isolated, are called as monofascicular block when they are isolated. Isolated RBB or isolated LAFB or isolated LPFB are called as a monofascicular block. What is a bifascicular block? Bifascicular block at LBB by itself is a bifascicular block. And then you have to look at any patient with a right bundle branch block. Always look for the presence of LAFB. If there is right bundle branch block plus left anterofascicular block, then that gives a chance it is a bifascicular block. So bifascicular blocks are a little more dangerous than a plain right bundle branch block. Bifascicular block, because in case of CAD, and this is LED occlusion, can block, because RBB, right bundle branch, and LAFB, the septal occlusions, can produce a bifascicular block, which in turn can develop into a trifascicular block or a complete heart block. So this is important to pick up bifascicular block. Whenever there is an LBB, always calculate, look for the LAFB presence. A trifascicular block, a true trifascicular block will be an evidence of RBB plus an LAFB plus an LPFB. So this is the true trifascicular block. It usually doesn't happen that way. When there will be 2 complete blockage, and there will be intermittent conduction via the left posterior fascicle block. So you always have to calculate the PR interval. Okay, whenever there is RBB with LAFB, you have to look for PR interval. If there is a prolongation of PR interval in the form of first degree AV block or a second degree AV block or a then this will indicate there is a high chance of developing into complete heart block. Any trifascicular block, if the patient is hemodynamically unstable, put the patient on TPI and plan for a permanent pacemaker if the cause is irreversible. So you have to know about the blocks because these are all prerequisite for a complete heart block. All these things can develop, has a high propensity of complete heart block. A trifascicular has a very high chance, a bifascicular has a high chance, and monofascicular block are usually asymptomatic. But again, you have to look for the presence of any LAFB or LPFB in the evidence of an RBB.